on here. I know over 100 RSVP'd. So there's lots of questions. I saw some of the questions that were entered ahead of time, and Dean James Herman from the School of Community Medicine is going to wrap things up for us. I just want to say at the outset that I've had the vaccine, and my whole family has, including my teenage son, who doesn't like shots, but was very prescient and thought, I want to kind of have as normal a summer as I can. So he volunteered to get a shot as quickly as he could. So I want to say that as by words of encouragement. I also want to I put in the chat the link to the CDC's COVID tracking thing. And just to give you some basic numbers, 125 million Americans are fully vaccinated. That means for the 2-dose series, they've had both doses, or for the Johnson & Johnson, they've had the one. But if you go by people over 64, 85% of people over 65, I should say, so that's, our most vulnerable, our elders have been vaccinated, and almost 75%, almost 3/4 of those people over age 65 have been vaccinated. So that's obviously a great thing for our country, and which I would say, in my estimation, is why we've seen the number of infections and the number of deaths go way, way down. So we have a very distinguished panel of folks here today to talk to us about COVID vaccine, but really, and I want to emphasize, Tracy, I think, sent out around an email that says ask you to keep your initial comments brief, because we have a ton of questions that people want to get to, and I would encourage you, if you're in the audience, to go ahead and submit your questions in the chat or the Q&A, and we will do our best to get to as many as we can in this hour. So it gives me great pleasure to introduce our panelists. I mentioned Dean Herman, who's here today, who's going to kind of wrap things up for us. Dr. Christina Klein, who is a clinical associate professor in Department of Family Medicine. And many of you may know her from employee health and student health, where she's been instrumental in getting vaccinations for many of us on campus. And back when we couldn't get testing, helping folks get tested and helping administer all of these protocols, which were quite convoluted and cumbersome in many times, and kept changing. Dr. Morgan Richards, who is a faculty member who's actually trained in obstetrics and gynecology, but is in our Department of Family and Community Medicine. And Dr. Kent Teague, who many of you know, who is the campus assistant vice president for research. He's associate dean for research in the School of Community Medicine. He's also a professor in the Department of Surgery, and he is the director of the Integrative Immunology Center here at OU-Tulsa, and is an immunologist. So he teaches every year to our medical students, our PA students, about immunology, about antibodies, basically about vaccinations and what they are. So he can give us give you a very scientific level understanding about this. But I think I am going to give Dr. Klein the opening remarks. And don't take it personally, panelists, if I cut you off, because I'm just going to try to get to as many questions as I can. But Dr. Klein, do you want to go ahead and go first?
Hi, well, thanks for letting me join this today. And I am going to keep my remarks very, very short, because I think the most important thing today is to address any questions that people have. I think people have heard lectures and read articles and heard everything on social media that they can about COVID and about the vaccines. And I think now is just a time or a safe place to be able to express your concerns and questions. So I will say that right now in Oklahoma, our cases are down. We had for the last week, the week ending May 15th, we had 965 cases, which is extremely low for the entire state, and only 40 deaths. Our vaccines, however, that are being administered are going down as well. In fact, our vaccine administration dropped 12,000 doses in the last week as well. So people are just not getting the vaccine as quickly and as abundantly as they were before. I would say that right now is the time to get a vaccine, and not because it's a rule or a mandate or anything like that, but while our cases are down, now is the time to get the vaccine, not to wait until we start having another surge or COVID cases start going up, because then it doesn't work quite as well. If we get it now while the cases are down, then people have a chance to build immunity, and maybe we get out of this cycle that we're in right now.
Okay, that was very well done, very to the point and short. Thank you so much. Dr. Morgan Richards, I'd love to give you next segment.
Hi, everybody. Thank you for taking the time out of your lunch to come listen to us. Hopefully the information that we can give you today will help you in either counseling patients who are asking you about the vaccine, or help you make decisions personally about getting the vaccine. From an OBGYN perspective, the American College of Obstetrics and Gynecology, the Society for Maternal and Fetal Medicine, and the American Society for Reproductive Medicine have all come out in strong support of women who are attempting to conceive, women who are currently pregnant, and lactating women being eligible for the vaccine, really without limitation. The limited data that we do have has shown that it is safe in these populations. And what we know based on the data that we have available to us right now is that COVID-19 itself pregnancy itself is a risk factor for developing severe COVID-19. We've seen increased rates of cesarean sections of premature births associated with women who had COVID-19. And there's data out of Britain that was just published earlier this week showing that women who are diagnosed with COVID-19 at the time of delivery have about a 2-fold increase in stillbirth. So if we can prevent some of that infection in these women, we can really do good for all of these populations.
So before we go to Dr. Teague, Dr. Richard, I just want to clarify and ask you, so as clearly as possible, if you are pregnant or are considering getting pregnant, you're saying
get the vaccine.
All of the august bodies recommend get vaccinated.
Absolutely.
Perfectly clear. Okay, great. Dr. Kent Teague, you have indicated an interest, just go to questions, but are there any introductory remarks you'd like to make?
Yeah, I think last time we had a town hall like this, I was showing you sort of the basics of the immunology, and then we were talking about what was really great news of what we called efficacy, was how well the vaccines worked in the clinical trials. And the really even better news since then is the effectiveness of the vaccines, meaning is it really working out in the community, has even exceeded my expectations and I think almost anyone's. These vaccines are working really well across the globe, out in the community. They're working really well against all these scary variants that you're hearing. And the studies keep rolling in from around the globe that these vaccines are not only working really well, very effective out in the real world, but out in the real world, they're showing the same sort of mild symptoms that we saw in the clinical trials. So the last time I talked, some people were, a bit wary because of the newness. We now have tens and tens of millions of people's experience with the vaccines. And we're very confident that these vaccines are not only working tremendously well, but also tremendously safely. So that would be my introductory remarks.
Thank you very much. It appears as though Dr. Mark Harmon has just joined us. He is also from the Department of Obstetrics and Gynecology and specializes in high-risk OB. And Dr. Harmon, I don't know if you have fully logged on, but if I wanted to give you a chance, there you are, I see you.
I'm on now.
Great. Do you have any introductory remarks you'd like to make? We're keeping them short because we're going to just take a lot of questions. Welcome.
I'm ready to go ahead with the questions.
Very good. Okay. Well, thank you. So I have a lengthy list, but there are some popping into the chat. So I'll just go ahead with the chat ones. The first question I'm going to read is, do you think these will be like flu shots and be done annually? And then once vaccinated, what would be the impact? Oh, sorry, this is two questions. Let's start with, do our experts think that these are likely to be annual vaccine administrations?
I reviewed the ACOG data yesterday, updated as of April, and there was nothing about supplemental shots, although I've heard that it may be needed in 6 months or a year from now. Okay.
I think we don't know. And for listeners who don't know, ACOG is the American College of Obstetrics and Gynecology. And Dr. Teague, any thought on that yet, or from scientific literature?
Yeah, what we're seeing is antibodies will eventually start to wane a bit, which you would expect. And the data are still not perfectly clear just how long they're coming in. The good news has been studies going out 8 months are still showing protection. But as the antibodies wane, typically with our past experience with vaccines, as long as this virus is circulating around the world, we would want to boost. So we're still waiting on a clearer picture of what that frequency would be, and even the dosing and all of that. So I would stay tuned. I suspect there will be boosts required, but I don't know that it will be annual. We'll see.
Okay. Another excellent question that is on a lot of people's minds is about these novel strains or new strains. We hear about this in the news frequently. That is if we're primed to hear about COVID, if we haven't tuned it out. And that is, we have heard how effective the vaccines are against novel coronavirus, SARS-CoV-2, but then there are these variant strains from the UK, South Africa, many other places. So somebody is asking, how do we contextualize those new new viral variants with the vaccines? Anyone want to take that one?
We are still, right now, it looks like the vaccines are very effective against those strains. I mean, obviously, the India variant is kind of new to the United States right now. We actually, just from the epidemiology report for Oklahoma yesterday, they reported that there's actually 18 strains of that, or 18 cases of that strain in Oklahoma right now. We're not sequencing very much in Oklahoma, so it's hard to know exactly how many strains we have. But so far the vaccines are working fairly well. Just an important note as we go forward, the vaccines were never designed to completely eradicate COVID-19. They are effective against serious illness and hospitalization and death, but they were never designed to make it where nobody would ever get COVID. So you have to contextualize that as well as how well they're working against the strains and things like that. People who are getting COVID after the vaccine seem to have a much milder or even asymptomatic course if they do get it.
Okay, any additions to that?
No, I agree. I think the way to think about it is we have some variants that come up that maybe take a little more antibody to prevent you from getting colonized, infected, and potentially sick. But none of these variants have escaped or gotten around. You hear that kind of those kinds of words being used sometimes by the press, and that's not true. So being vaccinated and having a lot of antibodies and a lot of T cells that can combat whatever that is in the vaccine is showing that even if it requires a little bit more, most people have it. So we're still seeing the vaccines are still working. And that will play into the first question as we go along, whether maybe we need an annual boost or a booster shot to get those levels up even higher, or even to a different sequence of the virus. So, but for now, I agree with Dr. Klein. The variants, the data we're seeing, even with the new India strain, some data came out that I read just this week, that it looks like our vaccines are going to be able to handle it. It just changes somewhat how much of our antibody that you built up from your vaccine that you need to combat it.
Thank you. Okay, I'm getting Dr. Bratzler is on the call, who, if you don't know, is OU's Chief COVID Officer, and he's in both College of Medicine and College of Public Health. And he put in this helpful thing that I think the panelists can see. I don't know if our audience can, so I'll just read it. Of the first 17 Oklahoma cases of the India variant, 3 people had been fully vaccinated with the complete 2 doses of Moderna, and 2 patients had received only 1 dose, but all of them had symptomatic disease with the India variant. So keep in mind that a few of them had been vaccinated, but none of these patients wound up being hospitalized. So in essence, either the variant wasn't that strong or those that were vaccinated were protected. But that gets into, I think, an excellent question that somebody else has asked, which is, my understanding is that you can still catch COVID if you've been vaccinated. So the question becomes a little bit of, well, why should I do it then? Who wants to take that?
I'll take that one. And I think part of it is what we're seeing, even in response, in Dr. Bratzler's response, is if you're not vaccinated at all, you're putting yourself at tremendous risk, right? And we know that, we've seen the devastation. If you're vaccinated, you're going to reduce your chance, right, of having severe disease. And so just because you can catch it even post-vaccination, the amount of harm it's likely to do to you is greatly reduced. And ultimately, what we're really looking for is to not have severe disease, hospitalization, and death. So the vaccines are doing a really good job at that. I think there's at least threefold. I think one, you want to get vaccinated because you're going to be far less likely to get sick. So that's protecting yourself. You're going to be far less likely to even get colonized at all, right, with infection. But then thirdly, you need to get vaccinated to protect your patients if you're a clinician, your loved ones and family, because the data are showing that you're far less likely to transmit and give this disease to someone else. So there are a number of reasons to be vaccinated, but as Dr. Klein said, it's not our only weapon to fight this disease. It's not going to be foolproof, but it's going to be a really, really important weapon that we have to get this pandemic under control. And we all have to do it together.
And I would just add another reason to get the vaccine is not, I mean, none of us want to give it to anybody. None of us want to get severely ill or hospitalized or die from it. And we don't want our loved ones to do that. But there's also, it's very well documented that there are long-term complications that occur from COVID. And even if you had mild COVID and you're young and you're healthy and there's really, you don't fall in any of those categories that you would be at like increased risk, people are still having, I mean, up to 30%. They don't even know the full extent of how many people are involved in that. But right now, estimates are between 10 to 30% still have fatigue. They still have breathing issues. They still may have alterations of their taste and smell. Some people have neurological issues with brain fog and memory problems and concentration difficulties. So it's not, there's just long-term things that go along with getting COVID and not that are beyond the severe things.
There are also concerns for cardiology or cardiac abnormalities too in these patients.
So heart-related issues from people who get COVID. So another reason to hopefully not get COVID by getting vaccinated. So Dr. Klein mentioned about what some people call long haul COVID. One of our audiences asked about possible long-term consequences from the vaccine. So what do we know about the vaccine and the very justified fear that if I get this vaccine that's relatively new, is it going to harm me? I hear what you're saying about protectiveness now, and I hear about the pandemic, and that makes sense. But how do we know I'm not going to have some side effects, months or years from now?
Well, I think we have ample evidence over the last century of generating an immune response, usually antibodies and T cells, to fight off infections. And if you look at all of our past experience with vaccines of all different kinds, made in all different kinds of ways, they're all essentially doing the same thing. They're trying to make your immune system remember a pathogen it's never really experienced. You're tricking it. And they're all essentially doing that same thing at different levels in different ways. And our experience over all of those decades shows us that when we do have adverse events to vaccinations, they're generally very early in the days or couple weeks after vaccination, and usually mild and not severe. But even when they are, they're generally early and not long term. So in science, we use our past experience the best we can to predict what will happen in the future, and we do that with any drug or any treatment. And these vaccines are no different.
Thank you. I want to pivot here just for a second. A couple of questions around fertility and obstetric health. There's some really good questions. So if you came on late, Dr. Richards was very helpful in stating that the OB-GYN community, highly recommends vaccine for women of childbearing age, for pregnant women. There's really without exception. There may be select exceptions. I can let you comment about that. But here's a couple of good questions, which I hadn't even really thought of. So does anyone know, can the vaccine affect fertility? That is the chance to get pregnant if you're not already pregnant. And that would be a reason someone might decline and say, I don't want to do this if it's going to harm my chance for fertility, chance to get pregnant.
At this time, they don't have a lot of long-term data, but it's thought not to affect fertility.
Not to affect fertility. Okay.
In the Pfizer study, there were similar rates of women able to conceive after receiving vaccine as those women that were in the placebo arm of the study. Really no differences in fertility or fecundability rates in either arm there.
So that's worth mentioning. So you had, this was a large population of people were getting tested in the vaccine before it was emergency use authorized. You had a placebo group and you had a group that got the vaccine. And regardless of which group the women were in, they achieved pregnancy at the same rates. So
Yes.
that would,
Yeah.
we can infer from that, it does not affect fertility.
And
No, go
I'm
ahead.
sorry. So where this conversation came from was that the parts of the COVID vaccine share some portions of DNA structure that are similar to this incitin 1 protein that is essential for placental development. So the thought was that you form these spike antibody or antibodies against the spike protein that could interfere then with placental development. Everything that ASMR has published, that's the American Society for Reproductive Medicine, has very much not supported that. I mean, whenever they look at the histology associated with placentation, and they look at the vaccine, they do not believe that there would be that cross-reactivity with the vaccine, giving the body the ability to affect that incitin 1 protein.
Yeah, I would say that's a myth that's really going around. And that's a good point that you brought that up, Dr. Richards. And actually, I went and did what's called scientists do call a blast search and lined up the proteins, and they're actually not the same. So even the basis of the myth is false. So I think that's an unfortunate myth that's really roaming right now throughout social media, that it's good that we address, that we do not believe there's any truth to that at all.
A couple of really good questions in this topic. So I think we've kind of addressed this, but I'll ask anyway. If the vaccine is given to pregnant women, have there been any adverse side effects reported? And I think we've talked in general about side effects, and we have talked about it being recommended for pregnant women, but are there side effects maybe specific to pregnant women? And I guess specifically people might be worried about miscarrying or something like that.
Sure. No, there's no data to support that there have been any specific side effects to pregnant women. They do look at the side effects of developing COVID-19 itself. We talked at the beginning, we talked about the effects of that for pregnant women. And then I see a question here that's asking if it's more beneficial for the baby, for the mother to get the vaccine during her 3rd trimester or after birth while nursing. We don't have any conclusive data on either one, but we do have case reports showing us that pregnant women who receive the COVID vaccine and then have babies tested for antibodies after birth are showing antibodies present. And then we do have women who received the vaccine and then were reporting early to the safe vaccine sites with the CDC or enrolled in breastfeeding studies showing that babies who were breastfed to mothers who were vaccinated also had antibodies present in babies. Right now, you can't really delineate between the two and say one is more beneficial than the other, I don't think. The CDC does anticipate having study data for pregnant women they're going to start collecting this summer, and then they anticipate having that data ready for analysis by the end of the year.
Thank you. Okay, here's another sort of clinically specific one. Somebody asked, how effective is vaccine if the one receiving it is overweight or obese? It's a good question.
So that is an excellent question, because a lot of injections and things that you get do depend on body weight. But the way the vaccines work is they work on your immune system. So it's a stimulation of the immune system. It doesn't work on a basis of a blood level or how high the levels are in your system. It's the response that your body generates to that vaccine. And so that is independent of weight or BMI, however you want to do that. But we do know, so I always have a caveat the other direction too. We do know that obesity and COVID do not go well together. There are significant risk factors associated with being obese and getting COVID. And those people have a higher risk of hospitalization. They have a higher risk of cardiac and pulmonary issues. Just in general, they were one of the first ones that were eligible to get the vaccine as people who were obese. So we know that if you get COVID and you're obese, you're not going to do as well necessarily as somebody who is not obese.
I think the question is probably coming. There was some press about a small study with healthcare workers, I think at like 250, where they were just looking at antibody levels, and they saw a small reduction in the obese healthcare workers from the others, but there was no data about efficacy or anything like that. And actually, if you look back at the Moderna trial, they weren't designed to study obese versus not obese, but there were plenty of non-obese and obese people in them, and there was no difference in the actual efficacy of how well the vaccine worked. So they weren't, the statisticians here will say, well, they weren't powered for that. That's true. But when you stratify it and look, there was no difference. So the best we know now, whether you're obese or not, the vaccines provide efficacy. And of course, if you are obese, you're at much higher risk of severe disease. So you really should be vaccinated, and it should provide efficacy from what we know so far.
So again, I think it emphasizes that not only is it effective if you're overweight or obese, but it's in fact highly recommended because getting COVID or having COVID illness is much more likely to be detrimental to you if overweight or obese or have other chronic conditions. This is a question from specifically for Dr. T, which is a really good question, and I think speaks to one reason a lot of people have the term of art is vaccine hesitancy. That is, normal, I think, very normal fears about getting a vaccine. And it says this, it says, Dr. T, can you briefly explain how this vaccine seemed to have developed so quickly, and I think the collective vaccines, and why has the FDA not approved it yet? So keep in mind, all of the COVID vaccines, whether it's Moderna, Pfizer, Johnson & Johnson, have been released for use under what's called an emergency use authorization, which means they're allowed to be used because they're thought to be safe and effective, but they're not fully FDA approved. So do you believe that not being FDA fully approved impacts the decision for some people who choose not to get the vaccine? I guess that's kind of what I was saying. So Dr. T, or anyone else who wants to answer that.
Yeah, and if Dr. Bratzler's still on, he probably could pop a note for us as well. So first of all, as a scientist, I can tell you why it appears they were able to emerge so quickly, which was one of the great achievements of immunology and virology, to be honest. So I'm really proud of my colleagues around the world. It goes back actually decades of development of both vaccinations that would be able to use what's called a messenger RNA. So that's like the Pfizer and Moderna vaccine. And then decades of working on how to deliver something like this vaccine using common cold virus vectors, which would be the Johnson & Johnson or the AstraZeneca vaccine overseas. So behind the scenes, thanks to taxpayer dollars and corporate investment for decades, there has been lots and lots and lots of work, thousands and thousands of scientists working towards developing these vaccines. So they didn't pop up. The science didn't just get drawn up, in January and 60 days after seeing the sequence of this virus, there was vaccine actually being tested into humans. That is an amazing accomplishment, true. But the technology has been under development for a long time and making incremental steps and getting better and better. And so we were right at that precipice. We were poised, very fortunately, when this pandemic hit, to be able to exercise that, or to be able to use that, or to jump off that platform and test it. So I don't buy into that, oh, this is just brand new technology, why should I ever put it in me? That's not true. It had already been going through numerous animal studies, even small human trials for other types of vaccines, for some of these other problems that we've been trying to address. So that's not true. It is true that this new mRNA vaccine that Pfizer and Moderna have been able to do, this is the first time we've been able to get all the way to the clinic, to an emergency use authorization, to actually save lives with this new technology, which is a wonderful thing. So that's the first part. What was the second part, Dr. Schumann? Had to do with not being fully FDA approved, just being an emergency use authorization.
Right. And I guess, are you worried that somehow something will reverse and it won't ever become FDA approved? And should we be concerned about that?
I don't think we should be concerned about that in light of the pandemic and in the dangers of not being vaccinated. I think it is good that the FDA and other organizations around the world that have oversight, where, for example, you already have a vaccine that's working, even if it's not perfect, like the seasonal flu vaccine, before you would fully approve a new influenza vaccine, you would want to see, years of data to show that not only is it better or just as good, but it's just as few side effects, and even all delve into all the little tiny subpopulations of people, like some of the questions that have come up. What about during pregnancy? What about during age? All of that. That's what it would normally take before you would then approve a new vaccine for some disease we already have a good or an okay vaccine for. We don't have that privilege here. There was obviously a sense of urgency to say, okay, let's put it through the normal paces, which they did. Let's do the clinical trial. Let's give placebo to one, vaccine to the other. Let's do all the safety measures we would do with any new vaccine or new drug, which they did. And let's make it go through all of the regulatory people who look at it, scientists from every walk of life looking at it, making recommendations to the FDA, making recommendations to the CDC, showing it's really safe and it works. And then you give the emergency use, because that's exactly what it's for. This is an emergency. It's like, oh, it is safe for most people, but the clinical trials couldn't include every single kind of person on every kind of little, different type of treatment regimen or whatever. So to get full FDA approval, I think it's good that usually takes years. But I think people misunderstand when they see emergency use approval that somehow the CDC, the FDA, the National Health Service in the UK, that all these people are putting in untested or vaccines that aren't tested well enough that we don't really know the safety. That's not true. In fact, it would be hard to find any drug or vaccine that's had more scrutiny at this point than these COVID vaccines in the history of mankind. That was a long answer. I'm sorry if that was too long, but
well, that's okay. I hope it addressed the concerns of many people who have that question. I just wanted to say one other thing, just in terms of, I like to look at the big statistics, and I mentioned to you how many, hundreds of millions of Americans have now had these vaccines. So if you're still hesitant, that should provide you some comfort. Hundreds of millions of your fellow Americans. Dr. Wendelboe, who is from the College of Public Health, who's also listening in, just had a comment. He said, we're all part of a community and society, and getting vaccinated helps us get to herd immunity and quote unquote back to normal. And for those of you that actually still read newspapers, in today's Tulsa World was an editorial cartoon of there was one person wearing a shirt that said fully vaxxed, and the other person one that said sort of anti-vax. And the fully vaxxed one tore off his mask and said freedom in a big quote, and the one who was vaccine hesitant said, maybe he's onto something, i.e. maybe that. So in other words, if we're all vaccinated, the quicker we get back to normal and the quicker we resume, the quicker we put this to bed. Now, here's another obstetric question. It's a clinical question. So one of the doctors listening saw a patient this morning who's 34 weeks pregnant. The patient wants to get the vaccine, but has some concern about the vaccine inducing a fever right at 34 weeks. Any wisdom you can share there?
Generally, the people have a fever for 24 hours after the vaccine. But you have to watch them because other things could cause fevers in pregnant ladies, chorioamnionitis or something.
Okay. And another good one that gets to immunology and biology of the vaccines. And again, I think this is another very common question people have. Why do Moderna and Pfizer vaccines, why are they a 2-dose series, and why is the Johnson & Johnson just 1 dose? That probably skews to Dr. Teague as well.
Well, some of it gets really technical. They are different. The Johnson & Johnson's using an inactivated common cold virus to deliver their vaccine, compared to the Pfizer and Moderna that are just giving this little signal sequence that instructs your own cells to make the protein. And there is certainly debate on timing and number of doses as to what's best. Even Johnson & Johnson has a trial that's doing 2 doses, not just one of theirs. And so part of it was the looking at them and saying, well, with a single dose, you know, they were able to get to, in the US, 71, 72% efficacy. And as far as you getting the virus, that's really good enough, because they were close to 100% at keeping anyone from getting seriously ill or going to the hospital. But it gets pretty technical. You'd have to come down and sit down and talk with me. There's some technical reasons around why the one works a little bit different than the other two. In general, though, the more times you get a boost, your immune system bumps up your titer of antibodies, makes more memory cells for future infections. So whether you got the 1 or the 2 dose, again, to the question at the very beginning, I think it's likely that we'll be asking you to get another dose at some point. And time will tell whether immunity will last as long with the Johnson & Johnson as compared to the 2-dose vaccines of Pfizer and Moderna. There's no way for us to know until many months have gone and we continue to follow all the people.
That gets me to another common question that a lot of people ask, and I don't know if this is still the guidance, but I'll put it out there. People say, should I get this one or should I get that one? Should I get the Johnson & Johnson because it's 1? Should I get the other one because it's 2? And the answer has continually been, get the one that's available to you. Is that still the guidance? Okay, I see Dr. Klein nodding. Yes, I'll take that as to the bank. Okay, here's another great question to panelists. Is there any point, and this gets to the CDC guidance, this gets to Tulsa ending its mask mandate, this gets to the University of Oklahoma ending its mask mandate for, and we'll put aside clinical people for now, because that's another question, but we're talking about general students, staff, faculty who are not clinic facing, patient facing. Any point, if you're vaccinated, of wearing a mask, whether you're at the store, whether you're eating with other people, anyone want to take that?
So I'll take that. So as you said, Dr. Schumann, the CDC did just come out with new recommendations as far as masking for fully vaccinated folks. And the data on the vaccine is, again, I mean, we get more data every day as more and more people are vaccinated. And so the data as far as contracting the illness, as far as spreading the illness, is so good right now that they really do feel like it's safe for vaccinated folks to be able to eat in restaurants, eat with other people, not socially distance, be indoors without a mask. It's a good practice, though, to determine who you're going to be around. So while you may be completely safe from getting serious disease or hospitalization or death, are you around somebody that's immunosuppressed? Are you around someone who has not gotten the vaccine? Are you around someone that is at high risk for getting really ill from that? And Dr. Teague's mentioned it. I think I've mentioned it. There's still the chance, even though you're vaccinated, that you could get this. You could get COVID and transmit it. So, we all want to be cognizant of the people that you're around whenever you're just deciding to go without a mask. If you don't mind, I'll just go ahead and address the question as far as clinical and healthcare settings and stuff like that. So the CDC has not changed any of the masking guidelines for that. And I don't know when or if they will anytime soon. That is in a different setting. And so the guidance has not changed as far as healthcare workers and people who are patient facing wearing masks.
So that applies essentially nationally as clinical recommendations, and so not just locally or Oklahoma wide. That's that's helpful to know. So I want to pivot again, and there's a lot of questions, very understandably, about mandates, the idea that you have to get vaccinated. And so the university has said several things. Being clinic personnel is a whole nother kettle of fish. So I guess what I want to do is put this question out there, and I'm not sure we actually have the answers to these questions, but we can see what more comes in, and basically premise all of this by saying the university will continue to issue recommendations and or policies, but essentially I can cluster these questions. Is COVID vaccine going to be required by students? So I think the answer to that is pretty much yes, without, certainly we've encouraged our healthcare students, our health science center students. And I think for our non-health related students, you know, obviously if you're, I mean, at this point, all college students are in the age category, so it's strongly recommended, if not required. Many universities are now moving to the step of requiring. And if OU hasn't said that already, it's going to clarify that, and somebody can hopefully correct me if I didn't get that right. People want to know, okay, great. Yeah, so Josh might be able to clarify that for us if he's on. People want to know about discipline. So let's say that the vaccine is mandated and you decline. First of all, how do you decline? And second of all, what might be the penalty if you decline? And I don't know if anyone on the panel can answer that, but I guess again, the caveat, we'll have some answers for that coming soon. And okay, so this is from Josh Davis, who's the, if you don't know, Executive Director of Student Affairs. He said, it is required, the vaccine is required for those that are patient facing, all students that are patient facing, which includes Tulsa-based HSC students, but also social work, clinical mental health counseling students as well. So those are some Norman programs, but they're patient facing or client facing. And so those students are definitely required to have the vaccine. That's very helpful. I've been told that the declination form, that's the fancy way of saying I decline to have this vaccine for medical or personal reasons. The Office of Legal Counsel is still working on that. And so we don't, unfortunately at this moment, we don't have, coming soon, hopefully within the next week, I'm being told. So, and then there's just more subtle variants on that question. So what will happen to employees who do not vaccinate? Can we require it even if it's the EUA, the emergency use authorization, coming within a week under my, and the form, the decision to decline is going to be uniform across all of the campuses. And the conditions that will allow someone to decline are medical conditions. So presuming you have a talk with your care provider, your physician, nurse practitioner, PA, or religious grounds. Apparently there will be an exception for religious grounds. But don't quote me on that until the forms and instructions come out. And this is an interesting question that I don't know, again, if we'll be able to answer at this moment, but somebody very specifically said, under OSHA, the university is liable for any injuries to an employee if they make an employee take the vaccine. So in other words, will the university provide paid time off or sick time to employees who have a reaction to the vaccine? Also, if there's a terrible adverse reaction, such as death or paralysis, which are extraordinarily rare, but can happen, have happened to some vaccines. But I have heard few to no reports about this with COVID vaccine. Any takers on that? I can't really answer the OSHA question.
I just know, and Dr. Bratzler put it in the chat too, that OU Legal is definitely looking at any and all of these issues. That very question was one that came up as well. I also wanted to point out on the students thing that for research, if you look more carefully at what was put out, it's students not just facing patients, but patients were also defined as any human participant research subjects. So there could be a number of students that miss that they say, well, it's not a patient, we're just recruiting people. So I'm sorry I went back to that, but I meant to pop that in. So if you have any students that are face-to-face consenting human beings into clinical trials, that they fall under that same rule of that the other students do.
Believe it or not, I think we've gotten through a lot of these questions. And I just want to highlight this from Dr. Bratzler. He says more than 350 universities already require COVID vaccine. The Equal Employment Opportunity Commission has already stated that employers may require COVID vaccines that are FDA approved or authorized. So there's definitely lots of momentum going in that direction of making it mandatory. So if that helps you get to taking the vaccine, I hope that it does so. So there's two more questions I hope we can answer quickly, and then I'm going to turn things over to Dean Herman to wrap up. One person asked, if you had COVID, can you catch it again?
Yes.
Kent, you're nodding. Okay. And Dr. Klein, you're nodding. Go ahead if either of you want to tackle that one.
So we know, I mean, well, yes, the answer is yes. So we know that you have some immunity initially after the initial infection. And right now, kind of the working number is 90 days. But you can, for whatever reasons, you can catch this virus again. And I think there might have been a question at one point about the immune response that you get from getting the infection versus having the vaccine. And that comes, I mean, I get that question a lot, and then lots of other trails that go off of that also. But the immune response that you get from having the infection is not as robust as the immune response that you get from getting the vaccine. And robust meaning strong, longer lasting, that kind of thing. So the answer to the original question is yes, you can get COVID after getting COVID. Okay, and you beautifully anticipated that last question, which was, and I just want to clarify that. So if you've had COVID, you might be able to catch it again. If you've had COVID, you do have already built-in natural immunity, but that's probably not as good, the studies would tell us, as getting the vaccination. And furthermore, if you've had COVID, the illness itself, you can still get vaccinated. And in fact, it's recommended that you do, but at a certain time increment, which I believe 90 days. Actually, the newest recommendations are when your symptoms have resolved and your isolation period is done, you are eligible to get the vaccine. So while you have a certain time frame that you may have some safety or some immunity to the virus, that recommendation for the waiting 90 days is, they've changed that. And so now it is recommended to get it as soon as possible. There is a chance that you may have a few more side effects with that first dose. That most people don't get many side effects from the first dose, but there is a chance that you may have a few more, right, if you get it really close to having COVID, but it is still recommended that you get the vaccine. If for some reason when you had COVID, if you'd gotten monoclonal antibodies in the hospital or in one of the infusion centers, they are recommending that you wait 90 days right now on that, just because they don't know about the interaction from the passive antibodies versus the vaccination. Okay, and most people haven't had that, and if you have, you would know it, because it would be sort of a big time treatment for serious COVID that you'd be getting it. Right, I'm saying it because people hear monoclonal antibodies and they think, oh, is that something I have or whatever. All right, let's tackle this last one fairly quickly, and then I want Dean Herman is going to offer some concluding remarks. Last question popped in. Once you get vaccinated, can you tell if you've had COVID through an antibody test?
So of course, scientists are always like this. It depends on the test. Yeah, and I'm glad Dean Herman's going after this, so we don't want to end on something like that. Many of the tests, are just looking for the spike protein, which would show up roughly the same whether you were vaccinated or you had COVID. You could have had COVID, many months ago, and those antibodies are gone. And you would think, oh, I never had COVID, when you actually did. So the answer is yes. In a lab like mine, I can tell whether you were naturally infected or vaccinated. I can likely tell, even if there's no antibodies, that you were naturally infected or vaccinated based on what your T cells look like. But the commercial tests that you go out to get, you can't necessarily tell that you had COVID if you had it in the past and the antibodies are gone. And you can't necessarily, depending on the test, tell whether it was the vaccine or a natural infection. So it depends on the test, but we can in the lab, yes, but it's not something that you can easily do, just as a common practice out there as a person wanting to know.
So not available in a routine clinical practice. Okay, at this point, I would like to offer Dean Herman the opportunity for some concluding remarks. Dean Herman.
Well, good afternoon, everybody, and thanks to our panelists for doing such a great job of answering the tough and the not so tough questions, a lot of tough questions. And John, also thanks to you for moderating. I know that's not an easy thing to do. You did a great job. I think I was looking at the statistics, and it appears that in Oklahoma, 40% of the population has received at least one dose and 32% have been fully vaccinated. So that's about a third of the population fully vaccinated, which to me seems low. I wish that would be higher. It would make us all a lot safer. I think most of us on our campus here are working in some way in a health-related field, maybe right in a field or one or two steps away. And setting an example for the rest of our population as educated consumers is really, I think, really important. Now, as John said, I'm similar. I had the shot. I had it for the series of shots fairly early, and I was happy to do that. It's opened up a lot of things to me that I wasn't able to do in the last year. And I know that's true for a lot of individuals. People are looking forward to be able to travel, for example, people who want to see their grandchildren, people who have immunocompromised or relatively immunocompromised people living in their family who are on the edge of their seats constantly about whether they or that person will get sick and whether they'll be affected. And I think all of us pretty much know somebody. We either know somebody who has gotten severe disease or died from COVID, or we know somebody who knows somebody who that. So this is really life and death stuff. And we as Americans are not used to this right now. I guess the last time, well, when I was growing up in the 50s, I remember being very afraid of contracting polio, seeing pictures of kids my age in iron lungs. I think 100 years ago, people were worried about dying of diphtheria. Most people don't even know what diphtheria is nowadays. When I was training as a family physician, we saw people with all kinds of meningitis, Haemophilus influenza meningitis, Neisseria meningitis. These things are almost gone now. And why is that? It's because of science. It's because it's the same science that brings us chemotherapy for cancer. It's the same science that brings so many medical developments that allows us to keep people healthy. So many of these diseases have gone away completely, and I think some people just don't know. They don't know that that 100 years ago, a third of children died of infectious diseases before the age of 15 or 16. And vaccines have had a lot to do with that. Obviously, there are other factors: clean water, better food, all that. But vaccines have had a lot to do with really the decline of all of these infectious diseases. So it's on us right now, folks. And I just urge everybody to be vaccinated, everybody who works with us. I care about you. I care about all of our employees. I care about our students. I care about all of us and our families. And the way to really accomplish this is to make sure that we first and everyone we know goes ahead and follows the science on this, because science can be a wonderful thing. And as Dr. Teague mentions, I've heard him say this several times, these technologies, these messenger RNA vaccines, first of all, have been in development for a long time. They're amazing in the way they work. They're going to be used, these technologies are going to be used to do all sorts of things in the future, including fighting certain kinds of cancer and other things. There's a lot coming of this. We should all be grateful that we live in 2021 when we can take advantage of these incredible scientific developments. So I urge everybody to get vaccinated. These are great questions that everybody's asking, and I really appreciate all the forthright answers. John, I guess that's where I'd leave it.
Well, thank you very much. So if this is, if you were hesitant or are hesitant and this has swayed you, there will be some follow-up from this. First of all, somebody did ask, is this being recorded? The answer is yes. We should have said that at the outset. you'll get some follow-up if you registered and either were or weren't able to attend about watching the video if you want for this information. Secondly, there will be some follow-up information about scheduling your own vaccine if you haven't been vaccinated yet and you want to. I don't have that with me at this moment to share with you. I'm sorry about that. And of course, follow up on all of the issues with regard to the university mandating it, employer mandate, et cetera. So more of that to come. I really want to thank Dean Herman for his concluding comments. I want to thank our panelists, Drs. Teague, Klein, Richards, and Harmon. Thank our communications and marketing team for putting this together, and Renee Engelking, who I think prompted it by sharing a lot of the questions that she was getting. But so thank you very much for your attention and for the really, really excellent questions. We managed to kind of pull it in 1 hour, so that's great. So keep asking those questions, but please do. If there's nothing else you take away, please do get that vaccine. We're getting closer to normal, that's for sure.
Bye, everybody.
Take care, everybody.